Welcome! I'm so grateful that you took time out of your busy schedules to be here with us today as we discuss a topic that's really important to me and to the rest of the hospital and our surrounding community. I would like to give a brief public service announcement before we get started. Steve and I are not technically socially distanced right now at 6 feet. We are sitting next to each other because we are both fully vaccinated and sitting here, so talking to each other without masks. But as an aside, if you haven't been vaccinated, I would love it if you went ahead and did that. It's still important. If you haven't done it already, encourage your family members if you can influence them to do that. It's a great thing for our community and our loved ones and people around us, so in our hospital. So with that being said, I'm really excited about this news that we're meeting today to share with you. And if you weren't aware, if you haven't already met Steve, we have recently introduced a really important role to Onslow Memorial Hospital, and that is that of Chief Medical Officer. This is a role that's actually not at Onslow, but it's been around in the industry, the healthcare industry, for quite some time. In the past, it's also been referred to as a Senior Vice President of Medical Affairs. It is a role that's so very important because the person who functions in this role typically is a physician and acts as a liaison between our medical staff and the executive team. And Steve, by the way, who you're going to meet in just a bit, is actually a great addition to our senior leadership team. Really excited about it. But some of the functions that the Chief Medical Officer role has is to have oversight and responsibility for contracted services that we might have, to, again, act as a liaison between the medical staff and the executive team and the board, to represent the medical staff and medical services in our community at community functions such as civic affairs or Rotary or Chamber or really in any aspect of the community that he needs to weigh in on. You're going to hear more about this, but we have the good fortune of having a candidate who is very versed and very passionate about community health care, outreach, and population health. So that's another reason why it makes him such a wonderful addition to our team and our hospital family. I also am going to say this. We would not have the caliber of candidates that we had and the caliber of this particular person who's wonderful if it hadn't been for the incredible partnership that we have with UNC Health. They helped us recruit, pull resumes together, and we have the constant support and feedback of UNC Health at a system level and system support through roundtables and other chief medical officers that Steve or I or any of us actually can run by the UNC Health leadership in order to make sure that we're treating it the same way, as the system would, but also as a best practice. So when we looked at job descriptions for the CMO, things like that, we actually ran it by UNC and made sure that it was something that they felt was appropriate for our area, our region, our hospital size, and our community. Finally, the last thing I want to say is that Steve, and part of our job here in developing the CMO role, was to make sure that not only did he have that be a member of the team and have administrative oversight for things, but we also felt that it was important for him to experience kind of the daily operational walk of our physicians and medical staff. So he actually is working 25% of his time picking up hospitalist shifts, which is amazing. So with that, I want to introduce you to Dr. Steven Spencer, our new Chief Medical Officer, who we are so grateful, pleased, and thrilled that he has joined the OMH family.
Thank
Steve.
You. Thank you, Penney, for that great introduction. I've had a great 4 months here already. I've learned a lot. I've learned a lot about the Jacksonville community. I've learned the passion that our senior leadership team has for the hospital, improving healthcare, and really being a partner in the community. So I'm looking forward to the next few months, few years here, and all the great things that we can do together.
Steve actually started remotely first, March 8th, 2021. I'm sure all of you realize what was going on March 8th, 2021, because we were fully immersed in COVID. So the fact that he felt so passionate about starting here and being part of this family really went a long way, that he went ahead and started remotely with us and really got to know, went through orientation which was, I keep telling him this, it was orientation by fire hose. But but he went through orientation, and orientation probably lasted, it's probably still going on, but lasted a full 2 months.
I think it's a continuous process.
Yes, yes. So the floor is yours.
Thank you. So I think one of the things we wanted to talk about is sort of how did I get here?
Yeah.
Right? So I actually love telling the story, and we were talking prior to going live about should it be the 5-minute version or the hour-long version. So I'm going to try to give a more condensed version because I know you guys don't have all the time in the world.
I told him an hour and a half.
Right. So it won't be an hour and a half. So I'll give you the condensed version. So I do like to start at the very beginning, really, where I see my passion for medicine coming into play. And that, believe it or not, really is second grade. So in second grade, I like to tell this story because I was an average student. I was in a poor performing public school. And you would never have picked me out from the line and said, that guy's going to be a doctor and less more, CMO of a health system. But my mom had the astute knowledge and foresight to say, there's this program. There's this private boarding school where you can get a full scholarship, primarily for underserved, underprivileged children. Actually started in 1848 for that purpose. So she signed me up, took the test, did the application, got in, and actually started private boarding school in third grade. Everyone is aghast when they hear that. They're like, "Oh my God, you were in third grade and you started private boarding school." Well, it was sort of semi boarding because I actually went home every weekend, vacations and holidays. And it was definitely a culture shift, sort of like moving to Jacksonville from Philadelphia. but that was the first cultural shift. But the first few weeks, there was a struggle. A third grader in a boarding school, there was a lot to get used to. And I remember distinctly that one of the folks there at the school said to my mom, I don't think this is a good fit for him. You may want to remove him from the school. And she said again, with great foresight, let's give it a little bit more time and see what happens. Well, in the midst of all of that, the first marking period for report cards came out. In that first marking period, I got straight A's, which, again, coming from an underperforming elementary school, being an average student there, and then excelling here was something that totally transformed my worldview. The positive reinforcement, I still remember my third grade teacher, who became my fourth grade teacher as well, really pushed me. It became expected that I was the top performer in the school, and then it also transformed the behavioral aspect because if you're the top performer academically, you also had to have good behavior, of course. And so that sort of propelled me. In middle school is when I like to say I developed my thought that I would be a doctor. So I was choosing between being a doctor and a lawyer. And in sixth grade, I said, I want to be a doctor because lawyers have too much paperwork. Well, little did I know. That's not necessarily true, right?
Yeah.
But there were other pieces of it as I developed it further. I love the idea of the continuing learning. I love the idea of helping people. I love the idea of making a difference in my community. Those were really things that drew me even in those early stages to the idea of medicine. So that continued through high school, but in high school, I also had some limited exposure to folks who were in healthcare administration. And so I had some conversations with people who had family members who were in healthcare administration and learned that not only could I have this effect on sort of people on a one-to-one basis, but over populations. Whether that was a health system or that was a Department of Health, and I found that very intriguing. And so once I got that idea in my head, I said, not only am I going to be a doctor, but I'm going to be a healthcare administrator in high school. This is a true story.
Can I ask you a question? So,
Sure.
sorry, this is, and I should have asked you this before,
Yeah.
but it is a question that I ask in orientation of folks. And it just occurred to me with you, and you're very articulate about how you got here from start to finish. But was there anything from a health standpoint that you saw within your family, or you said that you had exposure to healthcare administrators, or how they interacted with patients, or because I routinely hear, we want to help. We want to help people. We want to be of service to people. So what about that personal touch or helping somebody? Was there something in your personal history that was directly related to health?
Yeah, and so I don't think I quite realized this, probably more in the past few years, but when I look back in retrospect, what I realized I was developing was really an appreciation for the importance of the social determinants of health. I saw in my community premature illness and premature death from a lot of things that could have been preventable. Certainly obesity, certainly substance abuse were huge things in my community where I saw that people were dying and having bad outcomes early on. And from an even more personal standpoint, my mom and dad died prematurely from some of those same ills. So as I look back, that certainly shaped how I thought about things, and also shaped, again, sort of my idea of the one-to-one sort of outreach to patients clinically, but also looking at sort of a bigger macro population and doing that sort of outreach.
Hence your passion for population health.
Correct.
It all makes sense.
Correct.
You have taken a journey, sir.
Journey.
I'm sorry to interrupt you.
No, that was great. That was a great question. And so it became a little more sophisticated, of course, as I went through college and medical school. So I thought I would spend my whole career in Philadelphia. I won't tell you what institution I thought I would spend my whole career at, but I was going to be in Philadelphia until my senior year. And I was able to tour Brown in Rhode Island and loved it. And actually, I applied for medical school in high school and was fortunate enough to get in. And so it was an 8-year program. So I did a regular 4-year college and then 4 years of medical school at Brown, which was an amazing experience, and I loved it. In between my 3rd and 4th year of medical school, as I had sort of had this initial passion for community outreach and helping folks and thinking about underserved people, and that was developing a little bit more, I thought, I want to be a healthcare administrator. I'm interested in sort of in the business aspects, but I also love this social service and public health piece. And so I thought about it, and I said, I think I want to get my master's in public health. So I took off a year in between my 3rd and 4th year of medical school, and I went to Harvard for my master's in public health, which was an interesting experience because I sort of did a hybrid. So I did epidemiology, I did biostatistics, but I also did accounting and finance. I got amazing opportunities, and I tell people this all the time. I got the opportunity to do a class at the Harvard Business School on managing nonprofits. And when I look back, that was an amazing experience. I mean, in classes, you always do case studies, Harvard Business Review case studies in every business school. Yep. We had the opportunity to have those CEOs flown into the classroom every week and actually do them live. Wow. Which was, of course, when you're doing, you're like, yeah, whatever, man, I need to get through this. But when I look back, I'm like, that was actually an amazing experience. Yeah. So I did that, did 6 weeks in Kenya, which changed my life for a medical rotation. Decided that I definitely did want to do clinical medicine in addition to my passion for healthcare administration. Going to do internal medicine because I love the continuous learning. I love the cerebral part. And so I came back to Philadelphia. I trained at Temple, did an internal medicine residency there, which was great, underserved area. And then decided that I would go about 10 miles up the road to a slightly different community. So not underserved, actually pretty affluent community called Abington. And I spent 15 years there as a primary care doctor and hospitalist, which was, again, an amazing learning experience because we had a very, very busy practice, and also one of the few hybrids left. I mean, really, it's split up now between hospitalists and primary care doctors. So a great clinical experience. And because I had already figured this out, 6th grade and then high school, when I started the position, I told them that I wanted an administrative position in 5 years. I literally had that conversation. And they said, sure, we'll give you an administrative position. So at about year 4, I said, okay, I'm ready to start talking about my administrative position. And they said, oh, well, we don't really have anything available for you. I said, okay, well, I'll look elsewhere for an administrative position. They came back to me a couple weeks later and they said, we have something for you. It's called the Medical Director of Population Health. And I said, what does that person do? We don't know, but we think population health is going to be really important. So that was great because...
What year was that? Was that around the Affordable Care Act?
That was 2009.
Okay, the year before, right?
Yes. And so that was great because it gave me some opportunities to really shape that program. And it was around the Affordable Care Act coming. So we got to do a lot of great things around value-based purchasing, process improvement, quality metrics. Did a lot of work, especially in the ambulatory setting, which, the hospital is always 10 to 15 years ahead. And so a lot of that work was already being done in the hospital, but the ambulatory setting was really the Wild Wild West in terms of population health and quality metrics. So I got to put a lot of those things into place. Got to do a lot of innovative programs, ambulatory pharmacy, a lot of work around scribes and those sorts of things. So that was a great learning environment, and I got to do a lot of great things. But then I started thinking about, what do I want to do when I grow up? What's the next step?
That's probably literal.
Right.
Literal. You were planning this in middle school.
In middle school, right?
I was a cheerleader in middle school. I had other priorities.
I was very focused. And so I said, well, I'm still thinking about business. I really like the business part. The financial part, even though I got a little bit of that in, when I got my master's in public health, and a little tiny bit of that with the medical director of population health, that was the piece I was missing.
Yeah.
And so I made a decision. I said, I'm going back to school and I'm going to get my MBA because I love letters behind my name. And I said, I don't have enough letters, so I need more. So I decided to do extended part-time program at Johns Hopkins. And I said, how do I put all of those things together? So the clinical piece, the quality piece, the safety piece, and the financial piece. And did some research, and I said, CMO. That's what I want to do next, is the CMO. So I thought I actually would wait until I finished my MBA, but actually this is COVID factor. So with COVID, I was like, let me look around and see sort of what a CMO does and qualifications you need, and let me start looking. And then I said, this Onslow, they have an open position for a CMO. And I said, well, let me apply for this, just so I can do some research, figure out what a CMO does, and they'll let me know when I get there. And one thing led to another. And once I learned more about the organization and the community, I was sold. I said, this is perfect. They've never had a CMO. I've never been a CMO. It's a smaller community hospital. I'll have my hands in everything. Mm-hmm. I'll learn everything about the hospital. And then the connection to UNC is great because there'll be a backstop. There are best practices. They'll help sort of make sure we're meeting those benchmarks that are important across the state and nationally. So I was lucky enough, although, Penney, of course, knew I was a little bit green in the area. She saw something in me and she said, we want you. And I said, I want you. So it was a perfect match, and here I am.
Yeah. We had, just so you know, we had about 20 candidates. I don't know that I've had this conversation with you, but we had about 20 candidates, and UNC helped us do the screening. We narrowed it down eventually to 5 candidates. And Steve really rose to the top. He did an amazing job in the interview process, and it was apparent that he put care of our community, really that true aspect of population health, first and foremost as a priority. And just his spirit overall is a great one. And when you tell your story, when you tell that story of your journey of how you got here, it is clear that you were pointed in the direction, and you took the leap of faith each time, or maybe not such a leap of faith, because you actually helped to make some of this happen. And it's just been a truly wonderful experience thus far in bringing him in and trying to develop and form what the CMO role can truly be going forward, and how we will affect change, not just in the hospital, but in our community also. So I'm very excited about that aspect of it. When you were interviewing, this is a very self-serving question that I'm about to ask you. Spoiler alert, self-serving question. What did you see about Onslow and the surrounding community that had you say, I can help there? I can affect change there and make this a better place.
I will talk about a few things. One of the things that I noted right away, and I had no preconceived notions because I had only been at one place.
Yeah.
And it's huge and it's large and it's academic and all those places. Not disparaging about that; it's a wonderful place, but everyone thinks they're the best.
Oh, sure. We think we're the best.
Exactly. And so when I came, I had no preconceived notions, and I was amazed at the caliber of talent that you have here.
Yeah.
The people that I met on those interview days, and I said this to people personally, I said, I wasn't sure, but after interviewing and certainly after being here for a few months, any of these people could fit right into that large, gigantic academic institution, no doubt. The thing I saw that was missing, or maybe there was opportunity for, was sort of maybe putting those pieces together, making sure they were working. I think
in concert with each other.
In concert, And then the clear thing I think I saw was making sure that physicians were engaged in it.
That they felt included.
Correct.
That they felt included, because I agree with him. I agree with Steve in that to a certain extent, the docs felt that they were separate and apart from daily operations. And we always want them included, but I will say up until this point, until your arrival, we really weren't doing the best job that we could in making them feel like they were part of the whole.
Right.
So this to me is just a wonderful, very important role.
Yeah. And I think, as Penny said earlier, really it is making that connection between the senior leadership and the medical staff.
Yeah.
I think that's really an important driver. I can say, being on both sides, even before I was in sort of an administrative position, you don't see all the hard work necessarily that the administration is doing. Sometimes you just see the thorns and you don't see the roses. And so you kind of feel, as a doctor, you're working really hard, you're seeing all these patients, but there's not a lot of support on the other side.
Yeah.
And I think helping each side to see sort of what the other side is doing is already an area that I feel like I had made some strides in it, and I want to continue to make strides in those areas.
So Dr. Spencer, in his role as CMO here, has responsibility. I gave you a really high level of what the CMO job description looks like. But Dr. Spencer has responsibility in every CMO position a little bit different. But he has responsibility for pharmacy, performance improvement, the emergency department service line, that's up through Joe Malfitano. Joe reports to Steve. He has responsibility for the contracted physician services, such as radiology, hospitalist program, intensivist program, lab, physician services. What if I left out? Anesthesia.
Anesthesia.
And then OAS, of course, which OAS, Onslow Ambulatory Services, is our employed physician arm. So our employed physician clinics, dermatology, IMPC, ENT, Onslow Surgical Clinic, that kind of thing. So, when you take a look at the things that you have responsibility for, where do you think you're going to affect the greatest change?
Oh boy, the greatest
Hard question.
Hard question.
He didn't know I was going to ask you these things.
So I will put something out there that I try very hard not to do. So a lot of my experience previously was in the ambulatory setting, although I spent a lot of time in the hospital clinically, and a lot of that overlaps. I did a lot of work with readmissions and transition of care and all those things. That's why I wanted to be a hospitalist. Actually, we talked about doing some work in the ambulatory setting clinically, and I wanted to be a hospitalist because I really wanted to be in that hospital setting. So I'm going to use an all-encompassing sort of halo. I'm going to use patient experience. Mm-hmm. So I think the piece, again, is we're doing a lot of great things around quality. We have a lot of great people in place to do those things. I think putting the pieces together, and I think also telling our story is an area where we have some opportunity. I think from a national regulatory standpoint, but I also think locally. I think locally people don't know the great work that Onslow is doing. And I think it's important from so many different aspects to make sure that people know that story and to make sure that they know that they can get the same quality of care at Onslow that they can get at any other regional health centers and really any place around the country. So I really want to work hard to really tell that story because I think that's important to keep people in the community. I think that creates value. I think keeping people in the system also creates value. When people have to travel distances to go to different places, that's not good for them, and it's also not ultimately, I think, good for healthcare. So I think that's the piece that I really want to focus on.
Yeah. So I agree with you on that, but I'm going to link something that you said earlier along with that conversation that we just had about quality scores or the patient experience. So Steve made a comment earlier that the team here, and it's not just the senior leadership team, but could go to any large, whether it's a tertiary center, but large healthcare system, healthcare institution, and function, best practice top game. The same can be applied when it comes to quality, safe patient care provided in our hospital as well. And in fact, it could be, included in the statement that he made. However, we have quality scores that don't reflect the incredible job that you all do in providing care. You all, I'm speaking to staff as if there are staff watching too, so I assume that they are, but our hospital staff provides amazing care to patients. And they do so in a way that's very safe and high quality, but our scores don't reflect that. And so if you hear Steve say that as something where he thinks he can affect the greatest change, it is first and foremost to make sure that we are providing safe, quality patient care. Secondly, from a reputational aspect too, but also to reflect the incredible care that our medical staff and our staff are actually providing. So I do think that that's going to make a huge difference. I agree with you on that.
And I think it's, my perspective is a good one. You know, when I'm on the clinical floors, just as it was when I saw the people who were working behind the scenes or in administration, and I was very impressed with that. And I no preconceived notions, and I went on the medical floors, and I was like, this is just like what I'm used to.
Yeah.
It's not different. I mean, you know, there subspecialties sometimes that are not there.
Yeah.
But the actual quality of care that these patients are giving, you know, you could transport that where I was before, and it would again fit right in.
Yeah.
I did not go on the floor and think, oh my gosh, you know, I've gone back in time or anything. Like it was perfectly seamless in that respect. So I was very, very impressed by that. But again, it's making sure that we're messaging that right, and the story is getting out to the community.
That's right.
The other thing I'll just mention quickly about the Jacksonville community that I was not expected. And I'll tell everyone my story about North Carolina. So for some reason, I've always been obsessed with North Carolina. Like I knew I was all.
This is fate.
That's
fate.
Fate.
I'm going to say it's fate.
So I was content to be in Philadelphia, born and raised in Philadelphia, love Philadelphia, as I told Penney, warts and all. But I said, if I ever move, I want to move to North Carolina. And I didn't know why, because I had only visited before 3 years ago. I had only visited North Carolina once. And that was, I visited the Triangle almost 20 years ago now to apply for residency. So I went to UNC, I went to Duke, I went to Wake Forest, but ended up in Philadelphia. But I've always said, if I move, it would be North Carolina. So then 3 years ago, I actually came here for a vacation. My plan was Myrtle Beach. That's where I wanted to go. But we stopped off to North Carolina. Love North Carolina. No disparaging remarks about Myrtle Beach, but I like North Carolina better. We came back again after I applied. Again, had a vacation. Loved it. But I don't think I had a true sense of the Jacksonville area, even with those visits. And I sort of, I started my career with underserved populations, and even when I went to the more affluent area, I still had a focus there. And I didn't know where that sort of niche would fit in, where that passion would come from. And I don't think I recognized that between Wilmington and Jacksonville, it's pretty rural.
Yeah, true statement.
And that population is very similar to the underserved population in North Philadelphia. Yes. And I was able to make that connection early on, and that's very exciting for me. Because I really love the idea of making sure that they're getting the same health care as the very affluent folks who have lots of money and who are educated. I think we have a unique opportunity here at Onslow, being the only health center in the county, besides our naval partners. I think we have an obligation because of that to be the very best we can be, and that's a challenge I take home with me every day. And when I'm making that drive every day to Hampstead, in between Jacksonville and Hampstead, very rural, on 17.
Have you seen a bear on 17?
I have not seen a bear.
Okay, you will eventually.
People keep talking about snakes, though.
Oh, okay.
Every time they have an example of something, they're like if you get a snake bite. I was like, why do people saying snake bites? That's not an example we use in Philadelphia.
You're going to see a bear on 17 eventually. It's going to happen. So you know.
Just slow down, right?
Yeah. Or speed up.
Yes.
All right. Well, should we open it up for questions right now?
Yeah, so we actually had a question submitted earlier from Maggie, and she wanted to know how your goals coincide with the organization's goals.
It's very, very good. So this is a great time. I think we've done a lot of work recently to make sure that our organizational goals match up with UNC's organizational goals. So we're now on
Absolutely.
that calendar.
Absolutely.
We're also working on our strategic plan where, it's built around these organizational goals and where's the health system going in the next 3 years. And most people have probably heard the story, but I usually like to couch things around the Institute for Healthcare Improvements, AAA. So, patient experience, value of care, and then population health. And we've talked about a lot of those things already, but briefly, again, with the patient experience, clinical quality improvements, making sure we're meeting our regulatory requirements, making sure our actual quality in the hospital matches the numbers and the scores that we're getting from these regulatory agencies is very important. Making sure when people come into the hospital in our ambulatory space that they're getting the same standardized care and that they feel that care is good and people are listening to them. That's part of the patient experience. The value of care I've talked about really around the growth of our health system, making sure that we keep things in the Onslow County community so that it's valuable for them, making sure we have financial stewardship of the hospital so we're here and we can provide as many services as possible. And then that third piece is really that population health piece, which begins with community engagement. We've started on our community health needs assessment, which really looks at our community, sees all the things that may need improvement or opportunity to improve health outcomes, and then we need to engage the community to help improve that. We certainly are very focused on what happens in the hospital, happens in our ambulatory clinics when people come to see us, but our other mission, of course, is to make sure we're pushing out health education and health services to people out in the community. So those are how I sort of frame my goals, which should, of course, coincide with the organizational goals as well.
Excellent response.
And we have another question from Jessica, who asks, what do you see as a physician's role in maintaining a high level of experience?
So the physician is really the captain of the ship, we like to say. It used to be that, I don't even know how you would describe it, but the physician was everything. But now they're the captain of the ship. So really what they're doing is now they have all of this help. They have the nurses, they have the medical assistants, they have the clerical staff, and you could even boil down to, the environmental services people and the nutrition
Sure.
people as well. So they are really the people that the patients identify as representing the hospital. So it's important that of course, providers provide clinical quality care, which is usually, for the most part, not an issue, but really it's that connection to the patient, making sure we're hearing the patient, making sure that all of their needs are being met, and not to believe that the only thing is, what medication did they get, what test or study did they get. A lot of, getting better improvement treatment is around, does the patient trust you? Do they believe you have their best interest? That actually helps to improve the outcomes for a lot of patients. So making sure that they're the ambassadors for, of course, the clinical quality piece, but also just the ambassadors for the hospital, utilizing all of those other services and making sure that the patient is aware of those services, I think is really, really important. So I think we have to get out of the mindset as physicians that our only job is the diagnostic part. I think making sure we're having that connection with the patient can be just as important to their outcomes.
You're so right. And you mentioned that earlier, that it's about patient experience with quality scores being part of that, but also, we talked about the Affordable Care Act coming to fruition in 2010 and how that's actually played out over the last decade. And one of the things that they said early on, which I think was a really huge paradigm shift for physicians, was that it's going to shift things from a cure mentality to a care mentality. And so I felt a little bit bad for the docs because, especially in the office, because here they were saying, but I got rid of the infection,
Right.
or I fixed the broken bone. That experience in my book is a wonderful
Right.
experience. That's A. That is an A rank, right? That is, yes, I always did what I needed to do because I cured you. Instead, the patient wants that. I'm going to sit down and talk to you for 30 seconds about the experience that we've just had and why I'm doing what I'm doing and where I think you're going to be going over the next hour or two if
Right.
you're in the emergency department, or next few months
Right.
if it's a longer relationship. But you're 100% correct.
The one I actually like that I think is great, and patients will appreciate this, So the paradigm shift in wait times.
Yeah.
So
Yes.
before it was, and especially post-COVID, it's even more different.
That's
So
right.
you wanted a full waiting room.
Mm-hmm.
If the patient waited 2 or 3 hours, it's because I'm so great, right? They will wait
That's
2 or
right.
3
They're
hours
gonna wait for me.
Right.
Yeah.
But no, that's not a good patient experience.
Yeah.
And in fact, you may have people leave, you may have people not get the treatment that they need because they're having this long experience. So again,
And they're not going to give you that Google star rating.
correct. So again, it relates to this could affect their actual health outcome.
Yeah.
So we have to think about it in that way and
Sure.
not just dismiss it.
All right, and then Kenya has asked, how will you engage the community with Onslow Memorial Hospital?
It's a wonderful question.
That's a wonderful question. So as we alluded to earlier, that's really, really important for me. And I don't think I articulated this well in the beginning. I sort of said there were some things I worked on when I first had my previous administrative position. But actually, before I sort of got more into the value-based healthcare quality improvement piece, most of what I did was community outreach. So I did a lot of health education. I created some programs with our local community nonprofits, including the YMCA. So that was a huge part of what I did. Now, of course, as time went on and they thought the value-based contracting was the most important thing,
Yeah.
that became less and less and less, but I didn't become any less passionate about it. So I think we have some great ideas for how we're going to engage the community. Certainly, I think just the presence will be good. Again, I think the community feeling like Onslow is their hospital is where we want to get to. Some people
Yeah.
already feel that way, but I think other people don't, and they don't have any clear loyalty. But I feel like, especially if you're in Jacksonville, but certainly in the larger Onslow County, you should feel like Onslow is your hospital, and that's where you should be going to, and that's where you should be supporting. Now, we have to do our part in doing that. But I think engaging those nonprofits, engaging those community leaders, making sure we have a presence in the community and they know that this is their hospital is where we're going to start.
All right, and then we have time for one last question, and this is from Christina, and she asked, telemedicine has changed healthcare delivery. How do you see this impacting patient experience quality and safety?
So, of course, with COVID, it accelerated everything. So that was one of the things that I was thrust into. I am not a CMIO, which is a Chief Medical and Informatics Officer, but I played one for a little bit because when COVID hit, we had sort of launched our telemedicine platform. Previously, no one took it up. Patients didn't want it. The providers didn't want it. We literally had 5 or 6, and I'm talking about a large ambulatory system, 5 or 6 a month. And then when COVID hit, of course, the offices closed, and then it was all telemedicine, and we had to sort of put together this whole infrastructure around telemedicine to educate the docs, educate the staff, and educate the patients. And then, of course, after the offices opened, it sort of dwindled down again, but it's still a large piece. So telemedicine has to be a piece of how we deliver healthcare. I think we're still working out where that fits in. We have a great opportunity in our ambulatory space, certainly, to use telemedicine and to utilize that to reach people. And it's going to be twofold. I think one is, I think we have opportunities to use telemedicine to reach people we weren't reaching before. So from a healthcare delivery standpoint, people who are high risk and need very frequent touches. One of the things that came from really the Affordable Care Act, I think, pushed us a little bit more is being responsible for the patient in between their visits.
Yes.
So that really high risk COPD patient or diabetic who you're seeing every 3 months, we need to know what's happening in between those visits so we can really affect their healthcare. So that's one of the places. But I think it's also, which sort of falls in line with patient experience, there are a lot of people who want that immediate health visit. They want to know that they can go somewhere, click something, and 15 minutes later they're going to have their answer. And so I think we have to meet that need as well. We have a great opportunity. We're actually doing an expansion of our EMR, which will upgrade it. There are some great telemedicine capabilities there that will help us. So I'm excited about that. That will occur in the fall, and we will have lots of programs around that. We also have a grant that we're going to be putting out there as well, which will help the community to provide them with some telemonitoring devices as well as some iPads that will help them to facilitate the telemedicine visits. And the last thing I'll say from the hospital perspective is that we are utilizing already our UNC partners for telemedicine, where we're going to be looking at some subspecialties that we don't currently have in the hospital for telemedicine. We're already using some telemedicine devices for psychiatry, which is another issue we want to tackle. But long story short, we're really going to be beefing up our telemedicine capabilities in both the ambulatory setting as well as in the hospital.
That's a great response. All right. Well, with that, we will wrap up this event, and I want to thank everyone for being present and taking time out of the schedule to be here. Thank you so much. I want to thank Dr. Spencer, Steve, for being present and telling his wonderful journey. It's an exceptional one, and feel free to spread that throughout the community to let everybody know.
And I was going to say, if you want the hour-long version, just give me a call, and I'll tell you the hour-long version of that story.
The other thing is, too, if you have additional questions that didn't come through during this Facebook Live event, please feel free to reach out to me or reach out to Steve directly, and we're happy to answer any other additional questions. But we have challenges before us that are translating into incredible opportunities, and I am so excited at the prospect of working with Steve to address those. So thank you so much for being here.
Thank you.
Grateful for your attendance and your interest.